No? Okay, great. Excited to be here today for this talk. I just want to acknowledge that my cover slide shows a picture of kids, just to remind us what an amazing privilege it is to care for our nation's future leaders, teachers, revolutionaries. Start with the statistic. 1 in 3. One prison is time. A boy, chance. Here's a great visual that I like from the policy. Shows on the left side the makeup of white, Black, Latino, and Native populations in the U.S. On the right side, population is a population. 4% of the U.S. population, they make 9%.
Dr. We're getting a cutout. It might be the connection. I know you switched the connection.
Oh, I did. Let me see if I can.
Do you think the other way is clear?
Maybe. Let me stop sharing real quick.
No worries. I don't know if it happened when the screen share went up or not.
Is this any better? I'm switching networks now.
Yeah, that worked. That seems fine.
Let's
see what happens when you do the slide. If when you do the slides, it's the bandwidth of the, I don't know this. I know enough tech to only be dangerous. Like if it's the slide, then
per 100,000 people. So that includes prisons, jails, immigration, detention, and juvenile justice facilities. So we have a higher incarceration rate in the district than any U.S. state. And while we don't have a good annual data source for prison growth after 2001, the data does exist that the DC area has the highest incarceration in the US, so therefore the world. And so for African Americans, the reality is even more stark. Here's another visual. It's from ACLU, and you are seeing census tract data from 2013 to 2017. And it shows that Black people in nearly every census tract in the district are arrested disproportionately higher rates than they're represented in the census tract. So for example, if you see, there are dots that show that Black people are about, 10% of that particular census tract, but represent 25% of the actual arrest in the district. So now you're thinking, okay, these numbers are staggering, but why are we talking about this at our research talk? And I'll come back to that. So let's first just set the scene quickly. So by the end of this talk, I really hope that you'll be able to list 2 to 3 examples of original and expanded ACEs, describe the relationship between ACEs and health, discuss examples of how ACEs and racism intersect and influence the health of children and adolescents, and then also explain the proposed factors for resilience and potential interventions. So we're going to start with some background on ACEs. So the original Adverse Childhood Experience, or ACEs study, was conducted between 1995 and 1997. It had over 17,000 participants receiving health maintenance or checkups in South California. And so the lead study author, Dr. Vincent Folletti, found that certain adverse experiences were common in childhood. These adverse experiences were categorized into 3 groups, which were abuse, neglect, and household dysfunction. Then those were further categorized into physical, emotional, and sexual abuse, physical and emotional neglect, and household dysfunction, which included household members with mental illness or incarcerated relatives, domestic violence or substance abuse problems, or if parents were divorced. And these individual ACEs are added together to produce a score. The score doesn't take into account the frequency of exposure, just if a particular type of ACE was experienced or not. And as you can see, incarceration is on the list of ACEs. And that's why we began this talk with incarceration, and we'll come back to it even later. However, the initial ACEs may not have adequately encompassed the breadth of adversity that minority, low income, and urban children experience. So Dr. Roy Wade in Philadelphia and his co-authors helped to capture additional experiences known as the expanded ACEs, and these children might experience. So these expanded ACEs include discrimination, economic hardship, negative life events, parental psychopathology, bullying, and community violence exposure. So why do we care about ACEs? Why am I lecturing you guys about ACEs? It's because ACEs impact both individual person and also the larger community. And when we examine at the individual level, we talk about the influence on genes, brain, health behaviors, and health outcomes. While I'm not going to focus on epigenetic changes or changes in brain architecture, please know it's a very robust field, and more studies are being done every day to show these relationships, and it's quite interesting. We're going to focus more on the direct and indirect influences ACEs have on health, including health behaviors, health conditions, healthcare use, and resilience. So we're going to touch on each of these a little later in the talk, but just so you can understand what I mean, people with ACEs are 10 times more likely to use illicit injection drugs and 7 times more likely to struggle with alcoholism. They're twice as likely to have ischemic heart disease or stroke, and 1.5 times more likely to have diabetes or cancer in adulthood. So now you know what ACEs are, you know why they're important, topics that you might have already known. But we're going to talk about something that I think is less frequently discussed within the context of ACEs, which is the intersection of ACEs and racism. I'm going to use some of my early work and the work of others to demonstrate why I think ACEs should not be talked about without a conversation about race or racism. I showed you before that discrimination is included as an expanded ACE by Dr. Roy Wade and his colleagues. And I think physicians and researchers should consider the influence of racism on child health. And as we mentioned, ACEs can have an effect on the individual and community levels. So I really see the clearest manifestations of racism as an ACE on the community level. So here is a graphic that I really like. I borrowed it from my colleagues at the University of Chicago. Here it conceptualizes adversity as a tree. And so we're going to start at the soil, down at the bottom. The soil is adverse collective historical experiences, and that's experiences that people experience as a group. So such as slavery, genocide, mass incarceration, displacement, the Holocaust. Those are the adverse collective historical experiences. And the roots of our adversity tree are in that soil, and they give rise to the adverse community environments. And that's where we see racism, discrimination, community violence, and then lack of opportunities, whether that's education, economic, or housing. And then those roots give rise to the branches and the leaves, which are adverse childhood experiences. And those are the ACEs we went through. And those are what we see that are a little easier to identify, ACEs, but the roots and the soil are just as important within our adversity tree. So as we mentioned, the roots of the adversity tree, which are the adverse community environments, include racism. This next graphic that I'm going to walk us through relatively quickly just demonstrates how racial discrimination materializes at the individual level of health problems. It gets under the skin. So a child can be exposed to racial discrimination either on the micro level or on the macro level. The micro level is childhood experiences like bullying, teasing, social isolation, but also through the observation of their parents, family members, and peers experiencing racial discrimination. And also parenting, how one is parented. It can be an exposure to racial discrimination or preparation for bias. But also these exposures are present on the macro level. And I think we're seeing a lot of that today through media, schools, social, political, and economic policies, as well as police and other media. So those exposures translate into physiological and also psychological responses with some familiar mechanisms: decrease immune function, increase cortisol, increase blood pressure and heart rate. And then those then translate into health outcomes and subsequently the disparities we see. So with birth weight, prematurity, increased risk taking, sexual high risk behavior, sexual activity, HIV, you know, kind of all of these cardiovascular, but also chronic health conditions disparities that we see. So I'm going to give you two specific examples from my work where I think ACEs and racism intersect. In these examples, racism as an ACE influences health behaviors, overall health, and healthcare use. So we're going to come back to where we started, talking about incarceration. And while the incarceration of a parent is considered an original ACE, I want you to understand that this specific ACE has a disproportionate effect on children and families of color. So we can't have a conversation about incarceration without talking about race and ethnicity. So I have a question for you, and I know we're on Zoom, so just think about it in your head. How many US children have had a parent incarcerated? And I really should add that they've lived with. Just think of a number. Hopefully you have it. So if you guessed 5 million, you were right. 5 million children in the US have had a parent that they've lived with go to jail or prison. And this number is 5 years old. So we know it's an underestimate because the rates of incarceration are rising. And it doesn't take into account the number of children who have had parents that have not lived with them go to jail or prison. And as we mentioned, the US has the highest incarceration rate in the world, and the district has the highest incarceration rate within the US. So we know that Black and Hispanic children, also rural children, and low-income children experience disproportionately high rates of parental incarceration. And while the majority experience incarceration of their fathers, maternal incarceration is increasingly now more common given the rising incarceration rates of women. So I wondered, how does incarceration of a parent influence the health of a child as they grow up? There's a growing body of literature that indicates parental incarceration is detrimental to health for individuals with that history. Specifically, asthma, HIV/AIDS, and depression, anxiety, and PTSD is higher among individuals with a history of parental incarceration. So for the study I'm going to show you, we asked two research questions. What's the relationship between the incarceration of a parent in childhood, so before 18, and the healthcare use and health behaviors in young adulthood? And does the relationship change according to which parent was incarcerated? We hypothesized that individuals with a parental incarceration history would have lower levels of healthcare use and a higher prevalence of unhealthy behaviors as compared to their peers. And we also hypothesized that those with mothers that were incarcerated would have stronger associations with these negative health outcomes. We used AdHealth for this study, which is a nationally representative survey of children, and followed them from high school into adulthood. Began in wave 1 with almost 19,000, was successfully followed up later with almost 14,000. And in our sample, we hit 13,000. At wave 4, respondents were asked if their biological mother or father ever spent time in jail or prison. We included individuals with any reported history of mother or father incarceration after birth, but prior to age 18, and created mother incarceration history, father incarceration history variables separately. We examined healthcare use in 3 dimensions of health behaviors, which were general health behaviors, substance use, and other high-risk behaviors, which were collected in wave 4. Within healthcare use, we looked at primary healthcare, dental healthcare, and mental healthcare. We examined general health behaviors of TV use, sugary drink intake, and sunscreen use. And regarding substance use, we looked at cigarette smoking, problem drinking, and prescription and IV drug abuse. And our final dimension was other risky behaviors, which included lifetime sexual partners, sex in exchange for money, and gambling problems. We controlled for wave 1 child sociodemographic factors like age, race, and gender, as well as family structure. We did parental education, receipt of public assistance, and geography in order to examine this relationship. So the highest percentages of mother and father incarceration histories were found in non-Hispanic Blacks, those in single parent households, households that were receiving public assistance, and those in urban settings. If you can remember, we looked at healthcare use and looked at these variables. For primary healthcare, young adults with any history of parental incarceration had a higher odds of needing medical care and not receiving it, while young adults with mother incarceration histories had 2 times the odds of using an ED or non-primary care setting for their usual source of care. And for dental health care, young adults with mother incarceration histories had lower odds of having a dental exam. For mental health care, young adults with father incarceration histories had higher odds of receiving mental health counseling within that last year. And then for general health behaviors, regarding TV use, young adults with father incarceration histories were more likely to watch more than 50 hours of TV or more per week. And sugary drinks, those with father incarceration histories were likely to drink 4 or more sugary drinks per week. And sunscreen use, those with father incarceration histories were less likely to use sunscreen. For substance use, cigarette smoking, we found that young adults with any parental incarceration history had over 1.5 times the odds of smoking cigarettes and higher odds of problem drinking. And for prescription drug abuse and IV drug use, young adults with any history of parental incarceration had higher odds of abusing prescription drugs, while those with father-only incarceration histories had higher odds of IV drug use. And our final dimension of health behaviors were other risky behaviors. Regarding the number of lifetime sexual partners, any history of parental incarceration was associated with 10 or more lifetime sexual partners. Sex in exchange for money, those with mother incarceration histories had 2 times the odds of having sex in exchange for money. And then finally, for gambling problems, that's gambling causing serious financial problems in relationships or friends or family. Parental incarceration was not associated with higher odds of gambling. So young adults with a history of parental incarceration during their childhood were more likely to skip medical care, misuse or abuse prescription drugs, and engage in risky sexual practices. So following that first parental incarceration study, we wanted to understand the relationship between direct and indirect exposure to incarceration. So in this case, I mean juvenile justice involvement. So yourself being involved in the justice system or the carceral system versus having a parent, which is an indirect exposure. So for this study, we asked, what is the relationship between the exposure to juvenile justice system, the direct exposure, and parental incarceration in childhood, which is an indirect exposure, and mental health conditions in young adulthood? And is there an additive effect for those that experience both parental incarceration and juvenile justice involvement? So we hypothesized that individuals with both juvenile justice involvement and parental incarceration would be more likely to have adverse mental health conditions, and that these exposures would be additive. We used AdHealth again, and we controlled for similar factors as we did with the first study. We used the same parental incarceration variable from the first study, and then for this study, used juvenile justice involvement. So respondents were asked if they had been arrested, convicted, or pled guilty to a crime or been found delinquent in a juvenile court, and the age at which they were incarcerated in that facility. We examined depression, anxiety, PTSD, suicidal thoughts, suicide attempts, and receipt of mental health counseling. We controlled for similar socio-demographic factors as our first study in wave 1. And similar to the sociodemographic characteristics of that first study, we found that those that had both parental incarceration and juvenile justice histories were more likely to be non-Hispanic Blacks from single-parent households, households that were receiving public assistance, and in urban settings. And we found that 1 in every 100 US children have experienced both parental incarceration and juvenile justice. We analyzed these groups by incarceration exposure. We looked at parental incarceration, which again is an indirect exposure, juvenile justice, which was direct incarceration exposure, and then both direct and indirect exposure. You can see that in general, for most of those outcomes, both having a parental incarceration history and juvenile justice history was associated with most of the mental health conditions that we studied. But we found that these, both juvenile justice and parental incarceration history together did not actually produce an additive effect on mental health. So ultimately, having juvenile justice involvement, that's the direct exposure, or both juvenile justice involvement and parental incarceration, were associated with adverse mental health conditions, depression, anxiety, and PTSD. The findings suggest that there's a relationship between incarceration and adverse healthcare use, health-harming behaviors, and undesirable mental health conditions. And we know that incarceration is an ACE with roots in structural racism and associated with those factors. And given the distribution of parental incarceration's influence on healthcare use and health-harming behaviors and undesirable mental health conditions, most likely to disproportionately impact these groups, Black, Hispanic children, rural children, and low-income children. And why, you ask? You already know the answer. Because of this slide. Similar disparities can also be seen by income and geography. So we talked about the intersection of parental incarceration and racism. In this next example, we're going to be discussing the relationship between environmental racism, a specific negative life event, and health. So in my opinion, the Flint water crisis is a story about racism, environmental racism, which shows up as community divestment and community trauma. For those of you that don't remember, the Flint water crisis occurred in 2014, and it's when the state of Michigan decided to save money by switching the Flint water supply from Lake Huron, which they were paying Detroit for, to the Flint River. And the Flint River was a notorious tributary that runs through the town, and it's known to the locals for being dirty. The switch was made during a financial state of emergency for the struggling town, and it was supposed to be temporary, while the new state supply, run supply was being ready for connection. But soon after the switch, the water started to look, smell, and taste funny. Residents also said it looked really dirty. The Flint water was not being treated with an anti-corrosive agent, which was actually in violation of federal law. And therefore the water was eroding the iron water mains and turning the water brown. And because half of the service lines to the homes in Flint are made of lead, and because the water wasn't being properly treated, lead and iron actually began to leach into the water supply. And, you know, according to local officials, about 40% of Flint's population are residents below the poverty line. And the majority of the Flint residents are racial and ethnic minorities. But when the Flint water crisis happened, I was at the University of Michigan, and I was wondering, asking myself, could something similar actually happen here in Ann Arbor, where the U of M is? Oh, sorry. We did a study of roughly 100 adults impacted by the Flint water crisis. They were enrolled in a larger study that was already ongoing in Flint, but we wanted to know if they thought that the Flint water crisis affected their health and also the effect of the health on their children. The population was mostly in their mid-20s. They were African-American females and with children on public assistance. So the entire study was bigger than what I'm going to show, but just so that you know, we looked at coping, financial burden, and health problems of adults living through the Flint water crisis. What we're going to focus on is just the concerns that the parents had for their children. So here I'm showing you what the parents stated in the study. Nearly 40% felt that there was an unexplained change to their child's health since the Flint water crisis, including rashes, abscesses, and stomach and digestive issues. and about 20% actually went to the doctor for their health concerns. It leads you to wonder, with the community adversity that we know and more direct health issues experienced by children, why such a large group did not go to the doctor and what their long-term health and health behaviors will be. You know, the crisis is fairly recent. It's been in the news again recently because of the settlement, but we're going to need to follow these children into adolescence and adulthood to really adequately study these relationships. And so what about experiencing racism indirectly? When I was a child, or when I was in high school actually, an unarmed Black teenage male was killed by a white police officer. And in the aftermath of that shooting, there was rioting, high racial tensions, a curfew from the city, pretty similar to what we have seen now. But it essentially divided my city and it left a huge impression upon me. And then probably even more profound, when I was at Children's National, I was pregnant with my son, and it was around the time of the shooting of Trayvon Martin. And I should have been really happy that I was pregnant and having this baby, but I didn't know Trayvon or his family, but I was really fearful about the fate of my unborn child. When I started my research career, I was wondering if this event and others like it affected children and their caregivers, like this one affected me. In essence, you know, did racism experienced vicariously or secondhand influence health? This led me to study vicarious racism in child health. I set out to answer the question and conducted a systematic literature review of vicarious racism. Again, that's racism that experienced secondhand. We reviewed nearly 1,400 articles to understand the state of the literature, and we found that there are three main pathways that studies identified that children could be exposed to racism vicariously. This is the pre-birth pathway through the mother. So a pregnant mother experiences racism, and they typically looked at the health of their newborn babies, prematurity, birth weight, and then also the post-caregiver or the post-birth pathway, either through caregivers or through another person or mechanism. These pathways were associated with the whole host of different mediators, moderators, and health outcomes. But the outcomes of the literature essentially were mixed, but the most robust literature out there was for the post-birth caregiver pathway. So a child seeing racism through the experiences of their parent. We found that vicarious racism was associated with decreased healthcare utilization, worse socioeconomic health, and mental health. Here's the abstract from the study, and it more simply, it just says almost 50% of the studies we evaluated showed that vicarious racism was associated with those main outcomes. Both my work with the Flint water crisis and also vicarious racism actually overlap. In an ongoing project that I'm working on in the city of Ypsilanti, which is about 65 miles from Flint, we're asking women, pediatricians, and social service organizations about the influence of the Flint water crisis on women and children in Ypsilanti, which is obviously outside of Flint. So how did this structural vicarious racism experience impact the health of children and families that were not in Flint? Whew. So we spent a large chunk of our time talking about ACEs and racism and the association with negative health outcomes. Now I want to spend some time talking about thriving despite these adverse childhood experiences. So why focus on resilience? It's because resilience offers the promise of mitigating negative health trajectories for children with ACEs. This is a simplistic graph, but I really like it because it shows that there's at least 4 possible responses after a child has an adverse life event. It assumes that a child only experienced one adversity, and it's not chronic, but bear with me. So a child is functioning at their previous level, at their normal level of functioning, and then an adversity happens. That's the blue line. They can succumb to the adversity and never return to that previous level of functioning. They can survive and have some impairment to their previous level of functioning. They can bounce back to their previous level of functioning, which is called resilience, or they can exceed their previous level of functioning, which is called thriving. So we're most interested in that right upper quadrant of that graph, the resilience and thriving piece. So what is it? Previously, the focus on resilience and thriving research really focused innately on the characteristics of an individual. It boiled it down to the 5 C's. So are they competent? Do they have confidence? Do they have character, compassionate, and are they well connected? Research also focused on some aspects of family. For example, family eating dinner together, attending religious services have been shown to be more resilient or thriving. However, for kids that are faced with ACEs, many times that family support is lacking. We've been slower to identify the specific community factors that promote thriving. One clear factor from that research has been the presence of mentorship, that it promotes resilience and thriving, but other community supports have been previously less defined. And I think these community factors are especially salient because of the presence of trauma in many communities. Community trauma is not just the aggregate of individuals living in that neighborhood or community, but the community trauma as a whole. So we talked about Flint, for example. We could talk about Anacostia. There are many manifestations or symptoms of community trauma at that level. Symptoms present in the social cultural environment, which are people, the physical and built environment, which is place, and the economic environment and equitable opportunities. So for example, the lack of equitable opportunities manifests as community symptoms such as intergenerational poverty, unemployment, disinvestment. The physical and built environment are unsafe public places. It could be manifesting as unhealthy products. And then within people, it can manifest as lower social cohesion, a lower sense of political or social efficacy as compared to those that live in communities without community level trauma. So for this, my research questions were, what is the relationship between ACEs and thriving? So to answer this question, we use a 2011 National Survey of Children's Health survey, which was a nationally representative telephonic survey of over 95,000 children. And our outcome was thriving, which, as you've heard, is a multidimensional construct, and there's many different conceptualizations of thriving. But for the purposes of the study, it was conceptualized as a child's ability to stay calm and in control when facing a challenge. We picked this question because it's been used before within the research, and one main theme within thriving is the ability to learn something new. And this likely happens after facing something challenging. This question was asked of parents of children 6 to 17 years old, and we dichotomized this variable where never and rarely were not thriving, and sometimes, usually, and always were considered thriving. So our exposure was ACE score, which was our the cumulative score of those affirmative answers to all the individual ACE questions. This survey actually uses household dysfunction, a lot of the questions from the original ACEs from household dysfunction, but also uses some expanded ACE questions too, like exposure to material and financial hardship, experiencing racism, exposure to neighborhood violence, and also the death of a parent. So we had 62,200 children, and in our sample, 52% had 0 ACEs, 24% had 1 ACE, and 23% had 2 or more ACEs. For children with 2 or more ACEs, the mean age was significantly higher than groups with lower or no ACEs. In groups of children with ACEs compared to no ACEs, Black and Hispanic children were disproportionately represented. Children with special healthcare needs were overrepresented, and so were children under 200% of the federal poverty line. We examined the distribution of thriving and found that 68% of children were thriving in this data set, but 32% were not. And our first research question was the relationship between ACEs and thriving. We controlled for child level, family level, and community level variables. And after controlling for those, you can see as ACE score increases, the probability of thriving decreased. Again, as ACE score increases on the x-axis, the probability of thriving decreases. So then the second part of my question is, okay, well, what are the community factors that contribute to thriving for kids? We examined community factors that promoted thriving, and we found that children who lived in neighborhoods that their parents perceived as safe had a higher probability of thriving compared to kids that did not live in safe neighborhoods. For children who lived in neighborhoods with 3 or more amenities, such as recreation centers, libraries, and parks, had higher levels of parent-reported thriving than kids in neighborhoods with 1 or less amenities. Parents who lived in neighborhoods that were perceived as cohesive had higher levels of parent-reported thriving. So that's, in this neighborhood, we look out for each other, those kind of questions. And then children with a non-relative adult mentor had higher levels of parent-reported thriving than children that did not have a mentor identified. And I bring up these family and community factors because as pediatric researchers, we can study the community environment, and as pediatric providers, we have the ability to help to encourage that some of these factors on the family and community level are really brought for these children and affect local change in our community. So finally, what about interventions for children with ACEs? This is what my Career Development Award is about. It's funded through NHLBI, National Heart, Lung, and Blood, and we're working to understand the relationship between ACEs and actually cardiometabolic health in adolescents. We're also examining a pilot intervention to equip adolescents that already have ACEs with the skills to thrive despite them. And as a reminder, ACEs have an important influence on cardiometabolic health, and many of those disparities in health conditions are stratified by race and ethnicity. Again, those with ACEs are twice as likely to have heart disease, severe obesity, and 1.5 times more likely to have diabetes. And if ACEs are addressed in childhood and adolescence, the poor cardiometabolic health trajectory may be avoided or lessened in adulthood. We know that cardiometabolic health in adolescents with ACEs is poorly understood. But what we do know is that ACEs create a harsh childhood family environment, which is associated with psychological distress and elevated BMI, which those together can predict higher inflammation and poor cardiometabolic health in adulthood. So knowing these things, so we're going to talk briefly about my ACHIP study design. We're still in the data acquisition phase right now as I'm starting the 2nd year of my K. I'm recruiting from 3 clinic sites associated with my hospital, and we're planning to recruit 500 adolescents from these clinics, ages 13 and 19. We're distributing an adapted but self-reported ACEs survey or questionnaire and health behaviors to our study participants. But because they're patients at our hospital, we'll be able to link their EHR data from clinic visits like blood pressure, BMI, and other health data with their self-reported data. And since the pandemic, we've also added questions about the psychosocial influence of COVID-19. And we already had racial discrimination questions, but are asking even more specific questions about the recent Black Lives Matter protests and police killings and brutality. So in a subsample of those 500 and 100, we are going to complete direct measurements, performing blood draws for inflammatory biomarkers, clinical and anthropometric measurements as well. And then as mentioned, both the psychological distress and elevated BMI puts children with ACEs at risk for higher inflammation and cardiometabolic health in adulthood. However, positive emotion may help to ameliorate the risk of poor cardiometabolic health by reducing psychological distress. So that's, we don't know the influence of positive emotion on ACEs in adolescents and cardiometabolic health. It remains understudied. So that's really the second part of my K. So in response to this, we're planning to adapt a positive emotion intervention for adolescents with ACEs. The intervention has been used in adults with chronic conditions like HIV or substance use disorders in order to help improve their health behaviors. And this intervention is 7 weeks, and coping skills and stress reduction sessions will hope to help adolescents focus on positive events, savoring, mindfulness, personal strengths, gratitude, goal setting, and acts of kindness. We have not yet started this portion of the study, so you'll have to invite me back again in 4 or 5 years when we're done, and I'll let you know what the results are. The intervention is really focusing on that top level where the leaves are, but we still, as researchers, pediatricians, and society, must contend with those adverse community environments and the adverse collective historical experiences that our society has faced and is facing. This picture is a picture of New York City high school students protesting the lack of indictment of Officer Darren Wilson in the shooting of 18-year-old Michael Brown, and this was December 1st, 2014. This picture could have been easily taken yesterday because of the little change in the last 2 areas of that tree, that community and historical piece. I showed this picture to remind us of how much work still needs to be done. If you remember nothing else from the talk, please remember that adversities in childhood are rooted in historical and modern day experiences that contribute to poor health in adulthood, and multi-sector strategies, including education, public health, research, medicine, and policy are required to disrupt this negative trajectory. I'd just like to thank the leadership at my hospital, Ann and Robert H. Lurie, and my co-authors and my research coordinator, Leishla Perez-Cardona, who reins us all in, and my amazing lab team. So with that, I would love to take questions and see if anybody has any. I know I was going fast. I was trying to make sure we had enough time.
No, you did. Left good time. This was excellent.
Okay, good.
Oh, yeah, this was good. Great, I thought. Thoughts or comments from the attendees? Oh, you can unmute yourself to raise a question or share it via the chat room.
I have a question.
Doctor?
Oh, hi. Yes, hi. Hi, Dr. Nia Heard-Garris. Such a huge...
Hi, good morning.
Good morning. Such a huge fan. I feel like I stalk your career. Congratulations. Thank you so much for this great presentation. Honestly, really just documenting how ACEs really maps on to the Baum-Brenner biopsychosocial ecological model, that kids are rooted in families that are rooted in communities, and that approaches have to kind of take both the individual level approaches as well as the systemic. And so I really liked how, you know, your project is starting to show some of the, you know, interpersonal and still individual level, you know, approaches that can really disrupt these cycles that can lead to intergenerational, you know, trauma and whatnot. For a future physician investigator who will be looking for a job in a few months, and also thinking about how I want to, you know, be submitting a successful K-23 in a few years, after 2 years after fellowship, thinking about what would it take to develop a systemic approach that ties in academia, ties in public health, and ties in some of the things that we're really talking about when we look at, you know, social justice. What would that look like in developing an academic approach to systemically dismantling the bad soil that leads to these pair of ACEs that you demonstrated with, you know, it's not just making the trees strong, right? The child is going to hear all these things, be affirmed, but if that tree is still rooted in the soil that is disruptive and dangerous and as bad as the, you know, lead-tinged water that people in Flint and other places are drinking, where do we go? And so what does that look like for the next generation of trainees thinking of systemic mechanisms using academia to really truly disrupt the terrible effects of ACEs and all the other systemic adversities?
Wow, what a great first question. What a hard one. Thank you for that. I can always count on you to ask me really thoughtful questions. I think, you know, as physician investigators, and especially the training that, you know, is happening at Children's National that I know, it is pushing us to ask these questions that are harder but no less important. And I think, you know, this next wave of researchers are going to have even more tools to collaborate with people across sectors, because as I mentioned, I think, you know, we're looking at patients that are coming in, and I think that's great, but there are a whole world happening outside of the clinic and the hospital walls. And I think partnering with public health departments, partnering with policymakers to really ask and understand the research questions that are needed, I think is a perfect first start in trying to think about what will it take to disrupt some of those historical collective experiences that have given rise to these community level traumas. They're never going to go away, but how can we ameliorate kind of the symptoms that we've seen from them? And I think Dr. Tarini has done an amazing job in partnering with people that have been outside of pediatrics or medicine to bring about change and bring about those important aspects to child health that are not within the scope of a provider patient interaction and really meaningful changes for child health. So I think that's a good question. I hope that it evolves, and I hope that our fields and research in general will understand the importance of these questions. I think Dr. Nancy Krieger out in Harvard has done some really great work in providing the data, because as researchers, we have, we need data. We can't just say whatever we want. We need to make sure that there's data and evidence there. And I think she's done some really interesting stuff with redlining and connecting redlining, this historical event that had happened over years and years, and associating that with birth outcomes and seeing like there is an association between these structural things that are hard to study and hard to measure, but can be measured if we think creatively, in child health. So I don't know if that answered your question. I think it's evolving. It should be evolving.
Good. That's very good. Go ahead, Pam, and then we have a comment from Randy.
So Dr. Heard-Garris, my name is Pam Hines, and I have the privilege of leading nursing research here. And I loved your presentation, and it's completely unsettling, as I think it should be. And I wanted to ask you, how is it that you maintain yourself as you venture into this area of science?
You guys are coming in with the hard questions today. That's a good one that I feel like I have never been asked really in a public setting either. It's funny because there was this, I'm a pediatrician, so I'm on Twitter a lot, and they were talking about this idea of radical self-care and what does that mean?
Yes.
And especially as, people of color, Black people, people that study heart issues, people that work with, vulnerable populations that are experiencing these adversities. It's hard to hear these stories. Mm-hmm. It's hard to carry that burden. And in order to do it well, I think you do have to practice radical self-care, whatever that looks like. So I've decided in this next year of life that I'm going to really try hard to practice radical self-care, and making sure that I'm doing the things that really fuel me so that I can have the time to think and reflect and say, okay, what is the next question that should be asked and answered? And who do I need to partner with? Who is doing the work? So I don't think that's a question that traditionally I get asked in research settings, but that's my honest answer, is really taking time for myself. And I think all of us, this is such a difficult time, the pandemic, the recurrent killing of Black folks. I think it's important that we do take time for ourselves and really understand what matters so that we can fuel ourselves to be able to do the hard work.
Mm-hmm. Thank you for that.
You're welcome.
And Dr. Streisand, director of our psychologist and psychology department, says, can you please remind us the assessment tools you use for both thriving and resilience in kids?
So for the last study that I showed in the talk, there were questions. So the National Study of Child Health is a really big national study, and they had already included questions about resilience and thriving. So I would have to go back and look there to say exactly what questionnaires they used, because I can't remember off the top of my head.
Built in them.
It was built in within there. But for the studies that I've got ongoing, I've used, there's the CD RISC, which is the Connor-Davidson RISC. I can't remember what the RISC stands for, but it's RISC. We've used those. There's also a assessment tool by Unger. I'm trying to remember what the name of it is, but a lot of people like the resilience tool by Unger because it's been tested internationally. So different populations, not only tested in, one racial and ethnic group, has been kind of tested all over the world. And the name of it is escaping me, but I think it's by Unger. There's a lot of actual tools out there. There's this systematic review that looks at tools based on age. And so if I can find that, I can send it to Dr. Tarini and she can send it out. But I really like it because it says, okay, in this age group, these are the ones that have been validated. In this age group, these are the ones that have been validated. But there are so many that are being developed, and some of them haven't been tested in the populations we really care about. So it can be a little tricky, but in that specific study, they were already built in. We just kind of use those same questions.
And then a technical question can you also talk about how you chose Ad Health versus the Fragile Families data set?
That's a very good question. It is practical. And I will say a lot of research and fellowship is like opportunity. And there was an opportunity because I had a friend who was in fellowship with me who really wanted to use that data set for something else. And so we went in together and used the data set because they had parental incarceration and they had some of the other kind of stuff that he wanted to study. And we kind of like divided and conquered so that one person wasn't carrying the full load of the cost of the data set and the cleaning of the data set. So that was really more of a practical use. But Fragile Families is awesome too. I've never actually
done in Fragile Families, the same analysis?
I think people have looked at parental incarceration and Fragile Families, but I don't think that same analysis has been done. And I keep putting it on my list to use Fragile Families, but I've never actually used them.
Yeah, I only know because Diogo teaches me these things. That's why I also wanted the Fragile Families so that we could have a better sense of because it's interesting to wax as on this as a health services researcher. The data sets are much like basic science, right? Each model is a model. Each animal model is an animal model. They're both different. They may not be the same. If they are the same, that's helpful information. If they're different, that's helpful information. Doesn't mean the finding is invalid. It could mean it. It just means the finding means something different, potentially, given how that data set was, how the people were recruited.
Exactly.
What was asked, how was it asked? I mean,
right. And Fragile Families, they actually recruit families that they've determined were high risk, right? Like, so it's a little less of a general population than Ad Health is, and just.
But I think that's also an important sort of frame, right? Not you, I'm saying like you have much media expertise, but hold on, Tony, I'm up here, just keeping it real, like school's out this week.
Hey.
So I think to the media, when these findings come out, true, not true, true, not true. I mean, right, that's, but at the same time, the goal being nuance without nuancing your way into blubbering with no one remembers. So
right.
The challenge as we deal with these issues that then get onto the news, you've done wonderfully with it, but just for those in attendance still, like this is the challenge in health services research, right? I mean, it's
absolutely
not all research. It's why the public is like, well, yesterday it worked and now you said it didn't work. And you're like,
right. We can eat eggs. Now we can't eat eggs.
Yes,
very confusing. Right. Are they good for your health or are they bad for your health?
Right. When the
right. And I think that's the challenge. And that's one of the reasons I'm grateful for the Robert Wood Johnson Fellowship, is because they said as researchers, you really should try to interact with the media, right, to disseminate the findings, because who better than you who actually did the study? But it's also challenging because you can't go into the minutia, of every single part of the study.
Right. It's not an RWJ talk where it's not an Academy Health talk where we're going to dissect it. But that's the other challenge, to sort of find that way to teach it right.
Exactly.
But it's important. And a skill you very much possess, so thank you. So your mentorship of future faculty.
I love it.
This was wonderful. I see that you are, to those remaining, I'll close it out, that you are speaking on September 22nd. Who knew? But you first saw it here. I want to be clear. You first saw it here.
Nia.
Hi, Dr. Hamburger. Okay, so Ellie Hamburger, CNMC legend, of course, was my continuity clinic.
Oh, I see now. I see.
Like she directed my primary care track program, mentor for life. I'm so happy to see you.
That was a fantastic talk.
Oh, thank you. You're biased, but thank you.
So yes, Dr. Heard-Garris, to give a plug, it's in the chat box for those remaining. Dr. Heard-Garris will be presenting on September 22nd at the Pediatric Health Network Grand Rounds.
Exciting.
The topic will be helping PCPs recognize structural racism as it may manifest in their practice and the way forward. So Dr. Hamburger, if you send us the link, we will disseminate it.
Very different talk, and it's going to be amazing. So be there.
Oh, yeah. Well, this was wonderful. Thank you for taking.
Thank you for the invitation.
I do appreciate it.
Yeah.
And if anyone has any questions, and your contact info is on the web, please feel free. I'm letting them contact you, and I will work with you. We'll get these scales disseminated.
Perfect.
Cool.
Thank you so much.
Thank you. Outstanding.
Bye.
Stay well.